All right. So again, welcome everybody. This is the first general meeting of the year, so I'm excited to see everyone here today. So a few items on our agenda. Of course, I wanted to welcome everybody today. I also want to introduce our new PCBH SIG leadership. We have several of them on the call. And we'll go through some brief introductions so you all can meet your new SIG leadership. We'll have some brief announcements, and then we'll share with you all our meeting schedule for the year. And then, of course, we'll have our discussion today on some hot topics in the past month, really, on the CFHA Listserv. And then I wanted to open it up for feedback, and hopefully you all will be able to complete a survey today that will help inform the planning for the rest of the year in terms of webinars and activities for the SIG. Just as a reminder, you can always go to our website. The QR code down at the corner will take you to our SIG page. If you scroll all the way down, you can click join the SIG. And then, of course, you can always go to cfha.net for job postings, blogs, and all the latest on all things integrated care. Also, as a reminder, if you would like to send a message to PCBH SIG members and really all other CFHA members, you can use the CFHA at gaggle.email. And also, I want to point out that Naftali recently sent out a message about how to personalize those settings in case you're getting a lot of gaggle in your inbox. You can create an account and personalize your settings as well as access files and everything else that has been shared on the listserv. Also, keep an eye out for our newsletter. It will be coming out before our next webinar. All right, so some introductions. So I am Gabby. I'm one of the co-chairs for the SIG. I'll turn it over to Laura, my other co-chair, who will briefly introduce herself, and then anybody else who is on the call.
Sorry, I had to turn the mute off. I'm Laura Schultz. I am the Senior Director for Behavioral Health in Methodist Le Bonheur Healthcare in Memphis, Tennessee, and excited to be joining for my first time doing one of these SIG leadership roles and participate alongside Gabby with her expert leadership. So.
Do we have anybody else on the call? Tulio, I see you. And I think I saw something.
Yeah, I'm here, Rachel.
Yes.
My name is Rachel Woody Mark. I am a behavioral health consultant in Nashville, Tennessee. I work for an FQHC called Connectus. I am the new early career representative, and I'm super excited to be serving alongside these awesome clinicians and learning from them and from you all.
Hi, I'm Tulio. I'm the SIG student rep. I'm a fourth year PsyD student at Xavier University in Cincinnati, Ohio. And yeah, I've spent my last 2 years in practicum in integrated care settings, which is awesome. And I'm hoping to continue that on internship next year. And yeah, I'm really happy to be here, learn from all of these famous names, which I can already recognize, and just contribute any way I can.
Great. And I think that's all that we have on the call today. Of course, we have Emily Faust, who's our member at large, and Stacy Grant, who is our secretary. All right. So this is our schedule for the year. We will be meeting on Wednesdays at 1 p.m. Eastern Time, 12 p.m. Central, and 10 a.m. Pacific Time. So we have our first meeting today, February 7th, and then after that, we will have meetings by Zoom in April, June, August, and December. Our October meeting will take place in person at the CFHA conference. In regards to topics and webinars, for our next meeting, we will have a webinar presented by our very own Laura Schultz, who will be talking about identifying and treating neurocognitive disorders in primary care. So that'll be the April 3rd webinar topic. And of course, we have that survey at the end of this call to hopefully get some ideas about what you all would like to see in terms of content for webinars. Just as a reminder, we do have the serving Latinx population group that is housed under the PCBH SIG. Leadership is Yaira Oquendo Figueroa. If you want to get connected with her, you can send her an email, but they are doing some great stuff to help contribute to meeting the needs of the growing Latinx population in this country. All right, just kind of zooming through really fast through all announcements. Just as a reminder, also, we have the PCBH SIG mentorship connector. So if you are looking for a mentor, or you want to get some experience and try mentoring yourself, we are looking for both mentees and mentors. There is a form that you can fill out. So if you are in need of a mentor, you can scan the QR code on your left. And if you are wanting to mentor, you can scan that QR code on the right. It's just a brief survey that will ask for information that will help us pair you with a mentee or a mentor. All right, so moving over to the topic of today's meeting discussion. So our listserv is very active. And so there's a lot of really helpful information that is shared, a lot of great questions, things to kind of reflect on. And so I know not a lot of people necessarily contribute by sending or sending a response. That could be, I know for some, could be an intimidating process to send this message out to the entire listserv. But I do want to recognize that there are a lot of people in our community that are very knowledgeable about what they are doing, very passionate about what they are doing. So we thought it would be a good idea to open it up for discussion. And so we kind of looked through the listserv about some of the topics that got sort of the most traction, some of the topics that got some high responses, and even some topics that we thought, were interesting and maybe didn't generate a lot of discussion. And so we listed a few. It's not if there's definitely some other topics that you all have recently seen and are not on here, we'd like to be open to discussing those. And so some of the things that I would like for you all to kind of consider in this discussion is maybe sharing what you know about this topic, maybe share, what does this process look like, or what, how is this done at your site? And then of course, any guidance or suggestions you have for others. So I want to kind of open it up now for really anybody to kind of step in, pick a topic, and we'll go from there. And if there's not one on here that you'd like to, of course, discuss that you've seen on the listserv, please let us know.
Hey, this is Chris Hunter. Can you hear me?
Yep. Hi, Chris. It's good to see you.
Hi. Good to see you as well. I know sometimes people are a little shy to start, so I thought I'd jump in and get the ball rolling here. I'll start with EMDR and PCBH since I actually responded to this one. I think there are a couple of things that came up when I saw this. I think one was I liked how people were thinking, how can we bring in evidence-based or evidence-informed treatments from specialty services and adapt them so they can work in primary care. So one, I like that. one of the things that I had some concern about is I think sometimes people kind of take what is, or can take what's in evidence-based or evidence-informed care, especially, and assume that it's going to work well in primary care. And I think sometimes they don't know what they don't know. And they want to jump to those things when there's an evidence base already for something that's adapted, like prolonged exposure, like Seagrain and Associates did, that is, 4 appointments, 30 minutes, tested in a clinic that was running a PCBH model of service delivery. And so those are some of my thoughts, I guess, when you're thinking about bringing in how you're going to most effectively treat the folks that you're seeing. Is it's great to think outside of the box, and at the same time, do your due diligence and look at what's already there, that's already has some better established science behind it as being able to work for what you're trying to target. So I'll back out, and I want to hear, interested to hear what other people think.
Thank you, Chris, for sharing that and jumping in.
Hi, everyone. This is Stacy. I have no idea what we're talking about, but nice to see everybody.
Hi, Stacy. So one of the things that we're doing today is kind of revisiting some hot topics in the listserv over the last month. And so one of the ones that Chris started us off with is EMDR and PCBH. And he shared kind of some guidance, suggestions for others in terms of, looking to see what's out there already to help inform what they do and how they help individuals in primary care. And so we're kind of still discussing this topic. So if anybody else has any knowledge about evidence-based treatments in primary care, or guidance or suggestions of how you do it at your site, we're open to discussing this topic or really any others. But I would like to hear some responses with regards to this topic.
I appreciated Dr. Hunter sending out the prolonged exposure 30 minutes. I've been trained in prolonged exposure through the VA system, but I actually did not know there was a 30-minute adaptation. So that's for me to study and look into. I have utilized written exposure therapy, which came out of the National Center for PTSD successfully in a primary care setting. It was also designed with that in mind, with 30 minutes as kind of the base. So that's one thing that we've, I think, seen some success in as well. Stacy commented, we've presented on it a few times at CFHA. Are you saying you've presented on prolonged exposure or on the written exposure?
The PEPC, I presented on it pre-COVID years ago, and I know that's recorded. And then Sheila Rausch, the co-developer, myself, and Rebecca from University of Michigan, we just presented in Phoenix about some of the new updates in the research, since Rebecca's doing one of the first trials in FQHCs across the country on PEPC. So check I know mine is recorded. I don't know if the one from last year is recorded, but the slides are there. I would go to I don't know if it's on the webinars page, Kathleen, or past the conference pages. I'm not sure where they put it. Or no, CFHA Learns, just kidding. It's in CFHA Learns. So yeah, so that's, and going back to what Chris was talking about, I don't know how I don't know. I don't know how to best disseminate when posts are made like that, in terms of we have established treatments already that have been studied for people to. I appreciated, I think Jeff Goody also posted stuff too. But yeah, just to remind people to please go to the literature, go back to stuff that's been done at CFHA. Yeah, because we do have resources. So I think I find a lot of CFHA members just don't know things exist from just outside conversations I'm having with folks in the organization.
I just posted the link, I think, to Stacy's presentation.
Ah, cool. Thank you so much.
And it says get this course for $30. I don't know if I didn't log in, so I don't know if it's discounted if you're a CFHA member, but even if it's not,
free.
it's $30.
I think hopefully it's free for members. If not, email Naftali. But I think
Gotcha.
it's free.
I figured it
think
probably
there's a
was.
code. Hannah sent me a code one time that makes it free.
And it looks like this is a case example. But I think Dr. Hunter,
Right,
didn't you
mine
send
is
out
mine,
the
yeah,
protocol?
mine's a case example of how to actually do it in clinic, like step by step for BHCs, kind of like minute to minute of how to do that. The studies that have already been done that we presented in Phoenix were more of the larger scale studies that Rebecca is currently doing, and then Sheila mainly does it with the VA populations.
One thing I do want to kind of point out is really my appreciation for people wanting to help people with trauma in primary care, because I know sometimes we run into really complex trauma. And you know, one of the first things, you know, that could come to mind is, you know, I can't deal with this here, right? This is too much. Maybe, you know, send somebody out to specialty mental health. And so even the willingness and curiosity about how do we help somebody with trauma in primary care, something that I can definitely appreciate. And just like Chris mentioned, it's, you know, people who just maybe don't know what they don't know. And there are a lot of resources out there of how to support our patients in primary care who have trauma. Anybody else? So I also wanted to share with regards to the prolonged exposure for primary care. It has been translated into Spanish, and so there is a protocol in Spanish also, because I know that's often something that comes up. How do we, you know, can we provide this treatment in a different language? And so it's been translated in Spanish as well.
Well, and I think this is an instance of a larger challenge that I think full-time clinicians have. You know, when you're grinding it out every day and you're exhausted, you know, and you're doing warm handoffs over your lunch break and you only have 5 minutes to go to the bathroom every 4 hours. I mean, I think most clinicians don't want to dive into PubMed and say, oh, let me search and see, you know, what's the latest and greatest? And oh, yeah, here's a journal article, but how do I actually do that? And so I think the challenge for BHCs is how do they sort of, even if it's just on an annual basis, even if it's let me spend some focus time when I go to the CFHA conference, or how can I take, you know, whatever time I have and have some focus time and make sure that I'm updated on from one or two good sources. What can I do? What should I be doing that I'm not doing? Maybe what have I been doing that really doesn't have an evidence base? Am I seeing results from that? Yes or no? Am I tracking outcomes on that? I mean, just because it hasn't been studied in primary care doesn't mean it couldn't be effective. But I think that's sort of a larger issue. I know that, you know, at least that's how I felt when I was doing full-time clinical work. You know, it's just, you've got to make time to keep yourself up to date on what are the best assessments and interventions from a scientific perspective. So larger issue.
Thank you. Any other comments regarding evidence-based treatments in primary care, or, you know, treatments for trauma in primary care?
I think it would be interesting to hear from the group off of Chris's comment. How do we, as clinicians who are grinding it out every day, where do you fit that time to educate yourself on what you need to know? How does your site support that? And just to learn from one another if there are ways that we can do that better as administrators, as you know, leaders in the field. How can we support our teams to give them the margin that they need to be able to do that? So I'd love to hear ideas on, if your site does this really well, what do they do? If you're struggling, but you've somehow squeezed it in, how so? Like, I just think it would be good for us to have that discussion of how we stay up when we maybe don't get academic or protected research time or whatever to do that.
When I was starting the PCBH service at the organization I'm at now, I was the sole BHC for 45 residents and like 25 faculty was huge. And I saw a lot of need for trauma treatment in primary care since I'm fortunate to be at an academic health center where I could easily refer someone to CPT or PE. It's just 99% of the patients weren't interested in going somewhere else outside of our clinic. So I actually went to my medical director and spoke with him about, I had met Sheila and Jeff Seagrang at a conference for the DoD and basically asked them, I'm not in the VA, I'm not in the DoD, I am a BHC in an academic health center that sees a lot of trauma and how it impacts health outcomes. Train me. And they were very kind and included me in the VA group to actually get trained on this protocol when it first came out almost 10 years ago. And so part of that protocol is you have to do weekly consultation calls for 6 months in a row for about 30 to 45 minutes. And so I went to them and said, this is important. This is, I was 90% clinical. I only had a half day of admin per week, which also got flooded with patients anyway. And so I actually had them block out an appointment slot for me. And so I could use that time to be focused to join those weekly consultation calls to do that for 6 months. And that was incredibly helpful because I had a leadership that cares about our population. Not everybody does. And so they saw the need and they saw our patients don't like to go anywhere but primary care. They said, sure, we'll block, one of your time slots so you could do this consultation call. So that's something now that we have a bigger team, that's what I do now to get our BHCs trained in that protocol. So I would encourage you for not just this protocol, I mean, any protocol to potentially think about blocking an appointment slot. Sure, you're losing that RVU, but what's the benefit of that? Which our team was like, well, the benefit is far greater than that one slot of an RVU that you'd miss per week. We're having people get better, get healthier, function more. So to me, that was helpful. So those of you who are in leadership, if that's possible, I found that I was very appreciative of that as a new BHC coming into a clinic.
Stacey, so just to clarify, you somehow linked in, even though you were outside the VA, you somehow got into that group?
I did. I'm very persuasive.
Yeah. Oh, I was gonna say, how do you do that? I mean, I was gonna say
that's
it's
a
just
whole other
interesting.
talk.
Yeah.
It was a whole other talk, but yes. I think it was just perfect storm. They were at a conference. I was at a conference. They were presenting on the data with the VA. And so I literally went up to them after the talk and said, I know you don't know me, but I'm going to stalk you until you get me trained in this. And it worked out. They actually let me join the VA group. So I don't know how flexible they are with that now, since they're both so busy training all over not just the VA, but other health centers. But that's how I initially got trained. So.
Well, and Stacey, I think to that issue, I mean, having your BHCs go to leadership, and are your education efforts on parallel with your PCPs? Do your PCPs get time for ECHO? Do they get time for other virtual conferences or training or CE time that maybe you could have something that is similar if you don't already have that? I think in my previous job, what we would also do is every couple of months, we offer a town hall meeting at different times for people, because we had 300 primary care clinics across the country. So in that town hall meeting, we tried to make it when they would have their lunch, and we would present certain specific topics of, here's the X subject of the day, here's the latest and greatest on assessment and intervention, here's some articles that you might want to read. So, and actually push the PDFs out to them so they didn't have to. Here's some handouts you might want to use. And then we could also use those town hall meetings for any kind of questions that people would have, whether those were kind of administrative questions like, are you having trouble with your peer review process? Whether they were clinical questions. And so I know every system's isn't designed for that. But again, if you can go to leadership and you have the ability to put something like that in place, it just becomes part of the standard of what you're doing to keep yourself up to speed.
Sorry, I clicked when I shouldn't have clicked. See if I can go back. Oh, there it is. Anybody else have experience with advocating for this time, protected time, to stay up to date, or any other strategies others have used?
So we've been given we are given the exact same amount of time as our primary care providers, which I appreciate. So our behavioral health providers are just treated as providers. So we're given the same allotment for continuing education funds, as well as time. We get 1 week per year that we, like 5 days that we can take out to go to a conference, etc. Which I think is helpful. It obviously, to do something like this, you'd have to break it into smaller chunks. The only other thing that I can say that we've done that I do think is helpful is we kind of like steal little bits of time. We do intentional didactics with our team once a month, led by behavioral health providers for behavioral health providers, which is helpful. So we're all working in primary care and we're all covering relevant topics. Sometimes it's a journal club. Sometimes someone will present something that they get from a training that they attend in their week-long time off in small snippets, so other folks can utilize that information. So that's a helpful way that we kind of keep our teams learning, but it's not like a full certification in a evidence-based practice. So, but it's one little way that we've gotten permission to kind of keep learning going throughout the year.
Thank you, Laura. I did see your question about the manual for PEPC, and Stacy and Chris, correct me if I'm wrong, but you it's not something that is distributed unless you've completed the training and the consultation program. Is that correct?
Right, correct. Yeah.
So how does somebody, can somebody, just anybody, get connected, or do you need to be Stacy Obai to get
Right,
connected?
exactly. So right now it's really hard. We've tried multiple mechanisms to work with national organizations to provide, it's fallen through. It also with CFHA we tried, and that unfortunately didn't work. So right now, Rebecca Shirapeta, I'll put her email in the chat box. She's a research scientist with University of Michigan. She, I believe, is still collecting sites that would be willing to be a test site in her national project with this. The only piece is that you have to be an FQHC. That's the criteria. So if you're not an FQHC, you would not qualify. But if you are, all of your behavioral health consultants would be trained for free on the protocol. So anybody listening to this later, because I know it's being recorded, please contact Dr. Shirapeta. We've had a lot of folks, even from CFHA in Phoenix, reach out to the team to get added as sites. So she has a ton of sites now, which is awesome. So she's still, I believe, collecting sites. So right now, that's the only way for civilians to get trained.
Well, and you know, Stacy, I'll bring up another topic or another thing that this group might want to think about tackling. You know, you have an evidence-based assessment and treatment that was rigorously done scientifically. You got good outcomes, but now you have a dissemination and implementation problem. Because the idea is, and this may or may not be true, that not only do you need to be trained on it, that you need to, for, I don't know how many weeks you said you needed to do it, go in for kind of consultation or mentorship. And I think that that's appropriate, but did you really need that many? I mean, that's an empirical question. I don't know, but it sort of goes back to, you can have the best treatments in the world, but if you can't disseminate that so people know about it, and you can't disseminate it in a way where people can uptake that and implement it in their clinic, it's sort of useless, right? We've got a great treatment that only a small number of people are going to get, which is antithetical to the population health approach of a PCBH service delivery model. So I know a bigger fish to try to catch and deal with.
Yeah,
And that is
we
exactly
totally
what,
agree. We totally agree. It's not for lack of trying. Trust me, we've been trying for over 5 years to get this disseminated. So trust me, it's harder than one would think.
but I think that's exactly why people want to do EMDR, because those trainings are everywhere and everybody can get them. So that is why I think the proliferation of providers utilizing EMDR versus, I was fortunate to do internship and fellowship in the VA system. And so I did get trained in cognitive processing therapy and prolonged exposure therapy, but most of my colleagues were not trained in the same setting. So even though I don't know PC, I found written exposure therapy super easy to learn and feel competent in because I was trained well in CPT and PE in the VA system. And this is just there's a lot of overlap. I'd love to learn PC as a person who already knows PE. But if we can't train people, then the VA gets all that great care, which is wonderful. But I don't know about y'all. We see a lot of trauma outside the VA. So it would be really great. But that's, I think, why everybody, I know
Yeah,
in
no,
Memphis,
I
everybody does
agree.
EMDR. And
I hear you. You're speaking to the choir.
yeah.
We're trying.
So Stacy, I'll back channel you. Maybe you and I and Jeff Goody could have a brief talk, and
Okay.
Jeff Goody is going to have some insights, and that maybe if you bring more people to the table asking for something, and then if the VA doesn't want to do that, then is there a venue for CFHA, the PCBH Special Interest Group, for other people to start offering this, and it's not, you don't have to have the key to the VA door to get in.
So what
Right,
about the Center
right.
for Deployment Psychology? I did some trainings through them and they were fantastic. And you can get evidence-based training through that Center for Deployment Psychology. As a civilian, you can sign up and do the trainings.
I believe
Right,
there's
yeah, it's been
also-
on, we have quite a few groups on the list that we're working with. It comes down to contractual issues, just to be frank with folks. So we're trying, but I'd love to have conversation, Chris, with you and Jeff and anyone else. If you have other national organizations, reputable ones, especially ones that are connected to primary care, let us know. Just so we can add to the list of folks to connect with to see if it works.
I think you can also get trained. So written exposure therapies is also a brief treatment protocol for PTSD. I attended a conference recently, and some folks from the VA were presenting on their efforts to disseminate this treatment protocol, training for this treatment protocol to community mental health providers. And so that's another, I mean, of course, it's a brief treatment modality, and I think they have different approaches for that consultation hour, so that it's a little bit more accessible to folks in the community. And so I'd have to look up the exact website for how to sign up to that treatment, but that's also another evidence-based treatment that I know is out there.
Yes, I mentioned that one earlier, and I did some of my dissertation work with Brian Marks, who was one of the co-creators of that therapy. And that book, the manual, is easily accessible. You can buy it. So it's a lot easier for folks to access that protocol. And I can drop a link to that in the chat.
Thank you. All right. Anyone else like to share anything on evidence-based treatments in primary care before we move forward maybe to a different topic? We can stay on this topic too. This is sort of we're pretty flexible in this meeting today.
How about peer review process?
That's a good one. I'm curious to just kind of know who that is here have a peer review process in place where they're at.
So we had one at the FQHC where I started that program where we rotated behavioral health consultants reviewing charts at random for each BHC each month and then giving feedback. We had to have so many new patient like first visits and then so many follow-ups and so many peds and so many adults pulled at random for each BHC. And then they were given feedback on a variety of specific criteria that we pulled out. And we rotated the responsibility for that so that it didn't fall so heavily on one person. And I felt like that was really helpful. In our current setting, there was a peer review process in place for primary care that they asked that I just fold our providers into. I don't love it, but we're peer reviewed by a nurse practitioner. So I was able to give some feedback on what I would like some feedback specific things, but our health system just has several nurse practitioners who all they do all day is review charts, but it's not really a peer.
Hi, this is Megan. I'm in Madison, Wisconsin at an FQHC, and I do the peer review reviews for my team. We do them each quarter, and I randomly select like 5 charts from the quarter to look at their documentation from a certain visit and then give feedback. I use the form that I developed with CFHA, so it's with the documentation palooza events. It's available through those materials. It's a nice review of just different aspects of a SOAP note. So if you're using a different note format, some of the elements will work, but some of the specifics may not match up as well.
Megan, do you have the link to that you could share with the group?
I don't have access to the link right now. Sorry, I'm on my phone, but it is available on CFHA Learns because it's part of the documentation palooza events.
All right, I'll see if I can find it for
Thank you.
while we're
I appreciate it.
Yeah.
I'd be curious to hear other people that are doing this, sort of what discussion is there between what I would call an administrative piece of your peer review. So you have certain standards and you're going through the note and you're checking off, did you do this? Did you document this? Did you document this? That's an administrative standard that really, if you operationally define what those are, almost anybody can go through and do a checklist, and that becomes just an administrative thing, especially if it's sucking up time from somebody else, that whoever's doing the peer review will just go right through it. So I'm wondering, is there any more of a qualitative check? Did you ask appropriate follow-up assessment questions if something came up? What was the intervention that you did? Did that seem to be appropriate? So those kinds of things I think are very different. And then I think you also run into the idea of, if you're doing peer review on one of your colleagues and you see them mucking things up, well, that's a whole other uncomfortable issue. Do I bring it to them? Do I bring it to our supervisor? What's the ramifications for me? And so I think, all of those things can be challenging. And then, if somebody is having trouble, who has the authority to continue to look at that person and make corrective actions? And if those corrective actions don't happen, does that provider just continue to slide? And so I think I've seen all of those things be potential areas that diminish what a peer review could be if they're not intentionally thought about and addressed in an open way. Anybody have any of those experience or thoughts of how you're dealing with that?
I can actually kind of share, like, I feel like as the student, I'm always constantly nervous or like unsure of like, do I address this with, someone who is fully licensed and I'm still in that training? And I think something that's been really beneficial in my training thus far has been actually my supervisors really kind of like instilling in me this confidence and, reassuring me that it's okay to approach someone as a peer, regardless of our degree, license, etc., especially if it's something, Dr. Hunters, you were just mentioning that could be administrative, such as they failed to document safety planning or maybe they forgot another part like that, where it's okay because if it's like objective, you're just bringing it to their attention because you want them to improve, you want them to get better, you want the whole team to succeed. I've also never had an experience where someone's been like, you have no right to tell me this because I'm better than you, or like I have a higher standing than you. So I think a lot of it maybe comes down to like culture of like your organization. I'm wondering if any of y'all have that same thought or any other related thoughts as to like how do you build the team and what standard do you set, and if that then allows for peer review to happen in the first place.
Hi, this is Megan again. Yeah, I would totally agree. Culture is a huge part of it. And I appreciate the comments too from Chris in terms of objective versus subjective review. For us, we set it up, tried to be intentional with how we were doing it and really transparent with the team so that it was something that was built into the culture. We already have a lot of consultation that we do with each other. So this felt like it was like the next step in extending that. So I think that I like both of those comments very much. I appreciate this because it's helping me to think about what we're doing now and maybe what I might want to change moving forward.
I'm curious.
I saw in the chat just
go for it,
sorry.
Laura.
I just saw in the chat that there's different ways different folks are doing these quarterly. We were doing them monthly, so I really like the idea of pulling back to quarterly. But also, Courtney commented that that's part of their annual evaluation, that the lead does a standing chart review, which I think is really nice because then it can be expected and just part of the protocol, and so that you can expect to get that feedback too. So just commenting that I think there's a few different ways folks are doing that, and it can be adapted to your organization and your needs and ability.
I was gonna say that I was curious to hear from the group at what point they decided to have a peer review process, whether this is something that was already in place when they came in or it was missing and they kind of developed it, and maybe what factors they took into consideration when developing it. 'Cause, as we know, there's varying levels of integration and programs are at different stages. And so I'm curious as to, what factors people have taken into consideration when implementing a peer review process.
Hi, this is Arissa. So at my former organization, which was Community Health of Central Washington, which many of you probably are familiar with Beachy and Bauman. So we were told we had to start doing a peer review process. But ultimately, I think it ended up being a very valuable thing. Right now I'm at Peace Health, and it's kind of on my long to-do list to get it started with my behavioral health team. And I think, we did it monthly, and it was, I believe, 5 charts a month that we would review, making sure it was a good balance of initial and follow-up visits. We developed the form kind of together. I think there was some input on what we put on it, and obviously we wanted to make sure that the billing required pieces were in there, the ethical pieces were in there, but also was an opportunity to make sure the things that we want to make sure we're doing as PCBH practitioners were in there as well. And I think, definitely thinking about the culture of the team is important. So I think we had a team that really, really cared about each other and really cared about it being a really strong service. And, we had a shared mission and value around that. And that the chart review was incorporated in that. We're doing this because it's a quality assurance, right? Making sure that we're doing that good care. And I think we were able to really learn a lot from each other. What we did was there was a rotation. So everybody got to, at some point, review everybody else's charts and be reviewed. So we got feedback from every single one of the BHCs eventually, right? And we're able to give feedback. And I found it super helpful to see what interventions were my colleagues using? How were they filling out that section that we have? That's with the assessment and plan section. That's really that feedback back to the medical team about what's going on. And we tried to make it as seamless as possible, organized. We had some organizational support in that somebody else would choose the charts for us, and we just got sent a list of charts. And then the form, we had options of filling it out by hand or electronically. So, it was, again, a kind of a team effort in figuring out how to make it as painless as possible. And then the forms were given to the BHC themselves. So once you were done, you would submit it to the BHC and to our director of behavioral health. So our boss would get it as well. And I think the piece too, like the form was pretty, I would say, objective. It was a lot of like checking, was this present or not? So I think that eliminated a lot of that piece of that discomfort around giving that feedback potentially to your peers, because you're just like, it wasn't there, or this is what I'm not sure I'm seeing there. Like, cause I think there was a partial. So I think I answered all the questions there. But again, found it really valuable, and I'm hoping to do something really similar at the site I have now.
We did the exact same thing, Arissa. So in both of the orgs I've been in, I've started the program from scratch. And so, we kind of hit a point where I had done all the chart reviews. So anytime somebody new starts, I review all their charts, 100% of their charts, until I feel comfortable with their documentation. And then I kind of like set them loose. But then I hit this point where I was like, golly, I haven't done quality checks in a little while on this, person. I just assume they're doing their job like they did before. When I sent them through, I probably need to start a peer review process. So that's how it began for me. But then I implemented the exact same thing. So built a structured form where we were checking things off, but I also added a little spot where we could do comments, and we rotated it each month, who was doing the chart review, but then we built it into an Excel spreadsheet. So I could, as the director, I could see the feedback, and then also those were privately sent to the BHC. So they knew everybody was going to get reviewed every month, but by a different person. We were rotating that, and it was wonderful to get ideas from our peers on our charts too. So there was an opportunity, even if it wasn't something was missing, to jot a note and say, hey, as I was reading this, I was wondering, like, did you talk to the PCP about a potential thyroid issue on this patient? If not, just might be something to look forward to in the future, because it's a chance for them to get feedback, to start looking and thinking about things from different angles, which gets to that subjective piece that I think Dr. Hunter was referencing.
And I honestly feel like, as much, again, as like clinicians still in training, I think that objective feedback is always like very much needed. Like, I know it's like for supervisors, they have to give me that feedback because that's their role. I also feel like in my experience, I have really benefited a lot from, Laura, what you just described, that subjective input. I won't even say it's feedback, but just like, have you considered this? Or just things such as like, hey, I really like the way you wrote your note there and how you went through rule out diagnosis, or I think that also helps you kind of grow and develop. And if you just rely on a single person to do that, like if it was always my supervisor, or like in your guys' case maybe the directors of behavioral health or whatever it may be, objectively the notes and everything could be great, but also subjectively maybe you're missing out on some areas that you can improve that are benefit the providers or benefit the patient, etc.
All right, so I want to be mindful of time. We have about 7 minutes, and so I want to open it up one more time for any final comments, discussions before we start to wrap up. I mean, overall, it sounds like the peer review process is one, helpful to check off, administratively, that things are where they're supposed to be, and how they're supposed to be in the clinical documentation, but also helpful with regards to any type of feedback that's provided, if there's that opportunity to provide that feedback. Yeah, so anybody else have any comments before we start to wrap up? All right. I don't think it would be a good idea to unpack another one of these hot topics from the listserv. But of course, I want to encourage everybody again, if you want to send a message, have a question, want to get some input, in need of, really anything from your community, you can always use the listserv for that. It's a really helpful resource. And like I mentioned earlier, you can create an account with Gaggle and adjust your settings as well, and view all the documents that have been shared. And it kind of looks like an email inbox kind of I guess the interface, which is really nice. You can kind of view all the responses and search for terms. And so encourage everyone to use our listserv and create that Gaggle account. All right, so let me move forward. Oops. And so anyone who is still on here, we want to hear from you. We want to be helpful in what we provide as a SIG to our PCBH community and our CFHA community. We want you all to attend our meetings because they're helpful and you are going to learn something. And so we want to hear your feedback about what you want, how you want to spend that time with us. And so if you scan this QR code, it will take you to a brief survey where you can provide some feedback about topics that you'd like to see, whether you like the webinar idea, whether you want more of a discussion like this, whether you want to hear, from some panelists or maybe discuss a journal article. We want to hear some of your ideas. So take a few minutes. It shouldn't take too long to complete. It's also I sent an email. There's a link to it as well. So share it with your colleagues if they're CFHA members, so that they can complete this survey, and this will help us inform what we do for the rest of the year. And lastly, this session has been recorded, and so will the future ones, so they'll be posted to the website so you can access them. If you aren't able to make a meeting, you can always view those on the website. Our next meeting, again, is April 3rd at 12 p.m. Central Time, 1 Eastern. Oh, I forgot Mountain Time the other time I said it. These are the times and the zones. Again, our very own Laura Schultz is going to be presenting on identifying and treating neurocognitive disorders in primary care. So we hope to see you there in April. And thank you again for joining us today.